Hello, everyone. I'm Mark Rosenberg. I'm Vice Dean for Education and Academic Affairs at the University of Minnesota Medical School. Welcome to the final session of Mini Medical School, Evolving with the Pandemic. We're excited to have you here today and look forward to guiding you through our third and really interesting topic in the series, the long view, envisioning a healthier world. We're going to begin with a moderated discussion followed by a question and answer session, and you can submit and are encouraged to submit your questions to our panelists at any time using the Q&A box, which can be found by clicking on the Q&A button at the bottom of your Zoom screen. Please note that this session is being recorded and will be available starting tomorrow on the Office of Academic Clinical Affairs YouTube channel. We will share the link to the recording with you by email. So today we have the pleasure of speaking with a panel of experts on long COVID and ways of reimagining health and society as we move into the next normal, whatever that's going to be. I will first like to introduce Dr. Farha Ikramuddin. Dr. Ikramuddin is a physiatrist and an assistant professor in the Department of Rehabilitation Medicine in the medical school. Dr. Ikramuddin leads the mHealth Fairview Adult Post-COVID-19 Clinic, which specializes in the recovery of long COVID patients. Dr. Ikramuddin, what do we know about long COVID, and are there differences depending on the variant?
Hi, thank you, Dr. Rosenberg, for the introduction and inviting us to talk about our experiences mutually during the pandemic. Excellent question, especially as we are truly evolving with the various variants as they go by. Could you change the slide, please? Another one. Thank you. So during the pandemic, we've gone through so much. And so at some point, we do become poetic. What's in the name, right? Shakespeare said, that which we call a rose by any other name would smell just as sweet. So you see so many names for this particular entity that it becomes important to ask the question, why? Why do we need a single name? It's known as long COVID, long haulers, post-COVID syndrome, and so on and so forth. The definition becomes important. It's very important. The reason why it's so important is because we need to understand this disease, the mechanism of the disease. Only when we understand the mechanism that can we target therapies at certain points of those mechanisms proposed to bring about a treatment. So, and also in my experience, as I have been publishing, taking one name and sticking with it throughout your publication becomes important. Could we change, please? Change the slide. Thank you. One of my favorites is the PASC, P-A-S-C, post-acute sequelae of COVID-19. It is a term that was coined by NIH, the National Institute of Health. Now, how various organizations define COVID-19 or the long COVID is very important, because only when we are researching how we define the disease becomes very important. Depending on the acuteness or the subacuteness or the chronicity of the disease and the mechanism underlying it. In PASC is defined as a new, ongoing, returning symptoms experienced more than 28 days after the infection. Please change the slide. The World Health Organization defines it in a different way. If you look, I have actually made it in bold. What I think is important in this definition, since you see it's quite a long definition, probable or confirmed SARS. That's very important for me, especially as I am seeing patients in the clinic. to know that were they confirmed by a PCR test or were they probable? And you have to go back to the lockdown to think about this. When these patients were having the infection, but maybe it was not so severe that they needed to go to the ER. Some of them were even afraid to go to the ERs and the urgent care. So these patients were not actually confirmed by a diagnosis. And that absolutely does not mean that they do not have the disease or the long COVID that comes along with it. So the definition of World Health Organization is based on probable or confirmed SARS-CoV infection, usually 3 months after the onset of COVID-19. So this is 3 months after the onset versus the PASC, which is 28 days. It's very important when we talk about new onset or persisting infection symptoms. Therein lies the mechanism of how this disease folds out. Next slide, please. The CDC defines it as an umbrella term, uses a term called post-COVID conditions, and it has 4 entities within it. That is the post-ICU syndrome, which you can imagine many patients go to the ICU, so that's meant for that. It contains the post-exertional malaise, which is normally a part of the chronic fatigue syndrome, and it's part of this definition as well. The MIS, as it is called, more common in children, and autoimmune conditions. Just recently, I saw a patient who, in my clinic, who presented with a loss of sensation in her legs. Further investigation led to vitamin B12 deficiency, and eventually we found out that she had antibodies against parietal cells in her stomach. The parietal cells that secrete the intrinsic factor that is involved in the absorption of vitamin B12, leading to the anemia and the fatigue. So once these mechanisms were managed and her hemoglobin came back to be normal, she improved significantly, and I actually discharged her last week from my clinic. So that's why you can understand the mechanism is so important in managing and treating these patients. Next slide, please. Next slide, please. The proposed mechanism. So there are a couple, and I'll try to go through these. The first one that really is intriguing is the presence of the virus. There are several studies that I have put in here that you're welcome to look into. The first one is the study by Matsky. They actually analyzed on postmortem about 43 brains and found the virus in more than 50% of the patients that they were doing the analysis on, or subjects in this case. The virus RNA was actually present both in the cerebellum and in the brainstem and the cranial nerves area, which is very concerning. Also here at the University of Minnesota, we have also found the virus to be present in the GI tract lining, which kind of begs the question, is it possible that this virus is sitting dormant within our body? It has also raised questions nationally that are the reinfections truly new reinfections from a new variant, or is it the re-emergence of what is already inside the body? So quite a concerning finding, but that is one of the proposed mechanisms. Next slide, please. The others are altered homeostasis of the organs. As you would remember, there is reduction in the tissue macrophages that are inherent into the tissue, such as in the brain, it's the microglial cells. In the liver, it's the Kupffer cells. The bones is the osteoclast cells. And what we have found that these cells actually are reduced in these various tissues, making it difficult for the body to manage the infection and causing more damage. Interleukin-6 is another, has been found to be increased in those patients who show severe disease on hospitalization. So there are many approaches over here that I have written, and I don't think the 10 minutes that I have here is enough to talk about just the persistent inflammation that is seen in these patients. Next slide, please. Well, Overall, PASC is a pervasive disease. It not only generates a chronic illness, but it unmasks underlying conditions. Just this morning, I saw a patient with history of MS who was infected with COVID, and his symptoms right now, about 4 or 5 months after the infection, have been worsening symptoms of the MS. So his right-sided weakness is much worse. His word-finding difficulties is much worse. So what it does do is unmask the underlying conditions. It worsens mental health. And so it's very important to realize many of the patients that I see in my clinic I do monitor their PHQ-9 scores and the GAD scores, which is basically the general anxiety and the depression. And it's not the depression and the anxiety that cause long COVID, it's the other way around. When someone is not able to perform his daily activities, is not able to go to work, it will produce depression and anxiety. There is a lot of PTSD in these patients as well. The approach is a multidisciplinary approach, and it does impact the quality of life as well as disability. There is another patient I saw just today who is actually applying now for long-term disability because of long COVID. Next slide, please. So what about the variants? Initially, in the beginning, we had the initial COVID virus, and now we are being exposed to so many variants. And if you can see over here, so this one is the epsilon and other viruses. This graph actually starts in September 2020, but does not have information starting from March 2020 when the lockdown happened. The red surge over here is the alpha one. The green is the delta, and the purple is the Omicron. The Omicron virus is K and L, I believe. And there is a new one, variant called the XE Omicron virus, which is believed to be a recombinant virus from BA1 and 2, which happens when the infection happens in the same person, and there is transposition of genetic material leading to a newer RNA formation. So that's what we are expecting in the future. So you can see that each of this space in time have a certain virus that is more predominant. If you look at the history or look at the studies that I'm going to talk about following from here, the studies don't actually look at the kind of variants that affected or infected the patients. They are depending on this map of where the variants were most common to determine the symptoms of that variant. So you can imagine you can only take that the conclusions or the results with some thought. Next slide, please. So PASC symptoms based on variants. That was Dr. Rosenberg's question. The studies that I see are retrospective studies which I said, as I just said, do not identify which variant was the infecting virus. It is based on the era of the variant. It is as such not a cause, but more of an association. And there are so many other complex factors that impact the symptom production or the symptoms of PASC, not just the variants. It could be the comorbidities. For instance, a patient with diabetes, a patient with chronic kidney disease or in dialysis, patients who are on immunosuppressants because of transplantation may show very different symptomatology. Of course, the impact of vaccines also, as well as the treatment that they had when they were admitted. And there are many, many patients who were not actually admitted to the hospital and still have COVID. It's insensitive or it is not linked to the severity of the COVID infection. Next slide, please. So this is the study that was done by Spinici, and he looked at they actually looked at the symptoms produced by the alpha variant. And what they found is body aches and pains, brain fog, insomnia, anxiety, and depression were more common in the patients who had alpha variant based on the era. However, loss of smell and dysgeusia, which means impairment of taste, and impaired hearing loss was much less common in these patients. In the same study, they also found that if you were using a medication, which is an immunosuppressant, which is actually an interleukin suppressor, it blocks the interleukin-6. These patients were 6 times more likely to get long COVID, and those who were discharged with supplemental oxygen were 40% more likely to have long COVID. So as I was mentioning, there are so many factors besides the variants that impact the symptoms that your long COVID patient will have. I do remember initially in the first 6 months, many of the patients who did come to my clinic had a lot of loss of smell and taste. Next slide, please. This is a very interesting study, which is actually, it is a systematic review. They initially looked at about 2,100 studies and came down to about 57 studies. The mean age of the patients was 54 years, 56% were males, and 79% were hospitalized. For me, when I look at these studies, the thing that's most important is, are these patients hospitalized or not? Because when I see these patients in the ICUs on the floor, these patients who were hospitalized, who were intubated for weeks and weeks, and those who might have just been in the hospital, they do look very different to me compared to those who were not hospitalized and yet have the long COVID. I put these two subsets of patients in completely different buckets. The median proportion of COVID survivors with at least one symptom at 1 month was 54%. The intermediate was 2 to 5 months, and it was at 55%, and at more than 6 months, it was 54%. So similar numbers here. What we are seeing is about 54 to 55% beyond 6 months of prevalence of long COVID. Next slide, please. These are some of the studies that I'll talk very briefly about. Here is a study of 60-day outcomes in hospitalized patients. In these patients, the dyspnea was the most common. The death rate during the study was 6.7%, and 32% of the patient had persistent symptoms at 60 days. So a little bit less comparatively, but these are hospitalized patients. Next slide, please. This is 6 months, also for patients who were hospitalized. And here, 76% had at least one symptom at 6 months. So that's more consistent with what we are seeing, maybe somewhat a little bit high. Fatigue and muscle weakness was the most common symptom. But if you looked at these patients at 6 months, their mean or median 6-minute walk test was lower than the normal, what would be expected normal for their age, height, and weight in 25% of the patients. So this is very important. It does affect these patients functionally. This is a very interesting study. CT scans were done in these patients, and they were interviewed extensively and examined, and it comes out from Wuhan, China. Next slide, please. Here is another one at 61 days, but these are non-hospitalized patients, which is what makes this study very important. And I'm bringing these studies out to you just to show you how the prevalence differs in patients who are hospitalized versus non-hospitalized, as well as from different centers. This is from the University of Arizona, looking at 61 days. And here the prevalence at 30 days was 68%, and after 60 days was 77%. Most common symptoms were fatigue and so on. Next slide, please. Here is the 8-month consequences of patients who are healthcare workers. And one thing that I would like you to take away from this is that 1 out of every 10 healthcare workers had at least one moderate to severe long COVID symptom at 8 months, which is very concerning for many of us who work in the healthcare industry. Next slide, please. Here is a very interesting study. This is led by the Patient-Led Research Collaborative. I've had the pleasure of meeting with one of the writers, Lisa McCorkle. And this study shows an incidence of about 96% in 3 months. Next slide, please. And so what about vaccines? How do they impact long COVID? And if you look at this study from UK, which is a large study of about 1.2 million folks, where the symptoms were monitored through a mobile app. And they looked at these patients between December 2020 and July 2021. And what they found was those who were vaccinated had reduced odds of hospitalization. If they did get infected, their symptoms were fewer than 5, lasting less than 28 days. And the risk of developing long COVID was reduced by 50%. So you can see that getting vaccinated is very important to prevent long COVID and to prevent hospitalization. Next slide, please. Here are the data at the University of Minnesota, which is something that I've pulled out from our own acute data for the COVID and long COVID. In this, if you see the number of total number of patients were 1,988 patients, of which those who had breakthrough COVID but did not develop long COVID were 83%, and 16% developed COVID. So it does help. All these patients were vaccinated, so you can see the percentage of the Pfizer, the Moderna, and the Johnson & Johnson. And you can look at these. Those with, and they're fairly common, a little bit differences. All these are have a p-value of less than 0.001, so significant statistically. Age groups are, you can see those who developed long COVID were older than those who did not. And if you look at the Elixir comorbidity score, which is a very interesting score, and the higher the number means the higher the number of comorbidities that you will have, such as diabetes, coronary artery disease, stroke, kidney disease, and so on and so forth. So the baseline is those who were sicker did get long COVID despite of the fact that they were vaccinated. Hospitalization, average length of stay is about 15.8 days, but I'm sorry, 15.8%. And these were, if you look at those who had long COVID, they were hospitalized more often than those who were not. And of course, the same thing with the ICU. Those who got long COVID and breakthrough after infection, they were older, they had more comorbidities, were hospitalized more often, and were also in the ICU for longer. So that's the takeaway message from this study. It had, this data has not been published yet. Next slide, please. One thing that I do want to talk about is the disability. This is an older study before the pandemic. This is 2017 study. And here they looked at ARDS patients, the patients with acute respiratory distress syndrome. The ARDS caused in these patients is not due to COVID, because this is prior to pandemic. ARDS is seen in COVID patients as well, and is the main reason why they are intubated and ventilated and are in the ICU. So they looked at 386 ARDS patients from other causes and found that at 6 months, 49% who were previously employed were jobless. 44% were jobless at 12 months. And the factors associated with this joblessness was older age and prolonged hospitalization. Their mean ventilation days were 11 days, and average length of stay in the hospital was 22 days. So this is prior to the pandemic. So if you can imagine in this pandemic where the length of stay is far much longer, that the mean duration of ventilation for the COVID patients is much higher than 11 days. What can we expect for joblessness, return to work, and disability in the American population? And so if you were to ask me what keeps me up at night, this is what keeps me up at night, the return to work issues. In my clinic, the number of letters I write on workability about helping patients get back to work or preventing them from returning to work because they're fatigued or their shortness of breath and other symptoms are so severe that I want to save them from going back to work still. And working with their employers to get them short-term disability and so on and so forth has been a struggle. So and the reason I have gone into the basic science and have shown so much interest in the mechanism of this disease is to find an objective finding that can quantitate the long COVID. Because right now, what the disability lawyers and employers come back to me in their letters and say is, all the findings that you are saying, you're writing, you're documenting are all subjective findings. Can you give us any objective findings? So my mission has been to find something that can be objective, that by which I can quantitate these patients. Next slide, please. So PASC will be a main public health issue of our times. It's not going to be. It's not going to go away, and that's the long COVID. Whatever happens to the COVID infections itself remains to be seen. But PASC is going to be a major problem for us. I think I'm done over here. Thank you.
Thank you, Dr. Ikramuddin. It's now my pleasure to bring in Shailey Prasad. Dr. Prasad is the director for the Center for Global Health and Social Responsibility and a professor in the Department of Family Medicine and Community Health in the medical school. Dr. Prasad, how is global health being impacted as we evolve with the pandemic?
Thank you, Dr. Rosenberg. I think this is a very important question. And interestingly, like Dr. Ikramuddin suggested, COVID affects various parts of the body. What I'm hoping to do is to do a sort of a quick overview, because in many ways, COVID has been one of the biggest ever shocks we've had for global health. And the key here is to remember that COVID and COVID-related issues are one, but the spillover effect, that is something to be considered. I would like to start with sort of painting a picture of how deadly COVID has been. The Institute for Metrics in Healthcare and Evaluation from the University of Washington predicts that by the end of August of this year, we would have had more than 7 million deaths due to COVID-19. Now, the biggest challenge we've had is to attribute the death to COVID or something else that has happened because of the pandemic. And the reason I'm mentioning this is that around the world, if you look at the excess deaths that are seen, in 2020, 2021 alone, we've seen about 18 million excess deaths. That excess deaths could be from COVID, could be from some other condition that did not receive care. And that, I think, is an essential challenge this pandemic has placed on us, the spillover effect. And then again, to give you a little context, the total number of deaths from the HIV pandemic for the last roughly about 30 years, and again, the HIV pandemic is ongoing, has been estimated to be about 38 million. So you see how devastating this COVID pandemic has been to, all kinds of deaths. Now, here is a quick infographic to talk about what are these other things that have happened. Many infectious diseases have been interrupted. Treatment of many infectious diseases has been interrupted. Tuberculosis, we think that there's going to be an estimated additional 1.4 million deaths from TB by 2025. These are estimates. To give you a little bit of a perspective here, prior to COVID, in India alone, there were 28 million or so multiple drug-resistant tuberculosis. In tuberculosis, one of the main things we need to keep in mind is they need ongoing care for the complete duration of treatment. Sometimes that's about 9 months, sometimes that's about a year. And if you miss the treatment, there's a chance that that infection will continue with that person and spread to others. The challenge with the COVID pandemic has been tuberculosis patients have not been able to get the treatment as regularly as they have been in the past. So we don't know what the full extent of this, pre-pandemic 28 million multiple drug-resistant tuberculosis in India alone, what has happened to them? How many more do we have? And how many more around the world are we going to see over the next many years? You see the numbers for excess malaria deaths in 2020. In HIV, one of the estimates suggested about 673,000 additional HIV-related deaths in Africa alone. And again, in HIV treatment also, ongoing treatment is key. Here is a projection on maternal and child health issues. An excess of 2.3 million child deaths in a 12-month period and about 113 excess maternal deaths. These are devastating for communities. And in terms of services delivered, because of disruptions in care, we feel that immunization rates are going to drop down. The Gates Foundation is estimating that all the gains we've had in immunization over decades that are slowly progressing, by 2005, we were getting to a point where we were like, okay, this is great. We're getting more and more communities immunized. That has now fallen to pre-pandemic and probably setting us back by 2 decades. We think that there's going to be about 15 million unintended pregnancies because of poor access to care. There is this particular data that I sort of chuckled when I saw this. It said that cancer treatment has been disrupted in 42% of the countries. And I chuckled because I would say it's in 100% of the countries cancer treatment has been disrupted. And beyond cancer, other chronic diseases have also been neglected, or access to care has been significantly affected. Now, the part that is important to keep in mind, because of COVID, because of the lockdowns, because of productivity issues, and some of it is based on people affected by COVID, like Dr. Ikramuddin suggested, but others, supply chain issues, economy issues, tourism-related travel issues. Sri Lanka, for example, is facing a meltdown in the society because of economic downturn. This is something very important to keep in mind. And this recession that we're going to see is probably going to be the biggest we've seen in more than a generation. And the concern in health is not yet quantifiable. For every 10% drop in the gross domestic product, there's an estimate that malnourishment can exceed 5 to 10%. We feel that childhood malnourishment can exceed 20% in many communities because of this COVID pandemic. And the challenge is that we know that malnourishment can significantly affect brain development in children. And some of the effects of this malnourishment can last generations. What I mean by this is a child that is going hungry today because of the economic downturn of COVID, that effect can be seen for 3 generations. So the final story of the overall impact of this COVID has not yet been written and not yet been quantified. Moving on to some of the effects on mental health. And this is not directly related to the long COVID or the past that Dr. Ikramuddin talked about. We know that we've seen about excess cases of both depressive disorders and anxiety disorders because of COVID. And some of this is obviously because of lack of treatment, lack of access to care, but some of it is because of the societal changes that have occurred because of COVID. So with all this, the important thing to keep in mind is that COVID has not just affected people who have had problems with COVID, it's affected every facet of society. So today there's been a question at the macro level as to what are we doing? I found this very intriguing. This was a study that was published in the Lancet last month. And one thing that was intriguing is prior to COVID, there have been many measures of measuring the appropriateness of pandemic response around the world. Some of them have been studied extensively. For example, what's called the JEE, which is the Joint External Evaluation, or the Global Health Security Index. These are different kinds of measures that look at how equipped a particular society, a particular country is in handling a stress like a pandemic. What's fascinating is majority of these studies have shown no correlation. What I mean by that is even countries that have had very good scores on the JEE, very good infrastructure in terms of number of hospitals, number of beds, and very poor, what we call social vulnerability index, have also done poorly because of COVID. The 2 factors that have shown to have correlation, we know that corruption in a society is inversely related to infection and mortality due to COVID. What I mean by that is when there is significant corruption in society, the higher the risk of COVID, higher the risk of death from COVID. And the one factor that was fascinating to observe is communities and countries where trust is the highest. That is the best predictor for low infection and low mortality. Trust in government, trust in societal structures, and trust in each other. And I think this is a very important lesson for us to keep in mind as we go forward in not just handling COVID as it is now, because a quick reminder, we're not done with the pandemic, but also how we face future challenges to health in the global health arena. People have been asking, will this lead to a new world order? In the early phase of the pandemic, there was immense criticism for world bodies, including the WHO. I feel that this is not warranted, personally. The WHO's current annual budget is less than an annual budget of a large hospital system in the US. Imagine that. A body that is supposed to be handling problems around the world has a budget less than a hospital system here in the US. Would then that entity, in this case the WHO, have the power to actually make significant changes? The other part is the structure. Today, the World Trade Organization has more power than the World Health Organization. Is that fair? There's been conversation that we need to renegotiate our treaties from a health viewpoint. And I think this is very important. And I think in the post-COVID world, or maybe the word post-COVID is wrong, in this COVID era, it's very important to keep in mind that we need to look at health systems in a different way. Global health over the past probably about 40 to 50 years have concentrated very strongly on single disease approaches. And don't get me wrong, single disease approaches are very important. That's how we eradicated smallpox. That's how we've done significant advancement against polio. HIV pandemic has been, the numbers have gone down because of a single disease approach towards HIV. The issue, however, is the single diseases approaches will not allow for resiliency in health system. So I'm here to say that the future of what global health should be about looking at community-based, stronger primary care public health centered structures on which now you can place single disease approaches. I hope this gives a quick overview of what we are seeing in global health. I'll be here for more answering any questions in the future. Thank you, Dr. Rosenberg.
Thank you, Dr. Prasad. And now it's my pleasure to introduce Dr. Rebecca Wurtz. Dr. Wurtz is an associate professor in the Division of Health Policy and Management in the School of Public Health. She's also a board-certified infectious disease physician and population health informaticist who has worked in public health at the local, the state, the federal, and international settings. Dr. Wurtz, can you talk about that endemic? How do we get there? Thank you.
Thanks, Dr. Rosenberg. It's fun to be back in medical school. I'll just talk for a few minutes so that we're sure we have time for questions at the end. Endemic and endemicity has proven to be a controversial and confusing concept for a lot of folks in COVID. Perhaps because it has the words end and demic in it, seems to imply an end to the pandemic. Let's start by defining what endemic is not. It's not the opposite of pandemic, nor a situation at the other end of a continuum from pandemic. It doesn't mean harmless or contained. It doesn't mean that our need to take precautions is over. Next slide, please. For the Bridgerton fans here, endemicity means more of a complex minuet, a dance between immunity, viral variation, geography, and human behavior. In an endemic world, the virus circulates at varying levels among populations with varying levels of immunity. How people behave has a lot to do with how many cases there are and the severity of those cases. Next slide, please. For those not familiar with Bridgerton, let me use a less elegant metaphor. Endemicity is a game of coronavirus whack-a-mole. The virus circulates continuously at low levels, but it's not evenly distributed. A newly emerging virus can pop up at any part of the world and can lead to more and more dangerous cases. Virus circulating in a highly vaccinated population in a temperate part of the world where people are immune either due to vaccination or to prior infection and who spend a lot of time outdoors, results in a lower case rate. And public health and health officials have to be vigilant to know when a new variant pops up or an old variant enters a non-immune population. Next slide, please. Here's a more formal definition. We're attending mini medical school today, but we've all been to mini epidemiology school during the pandemic. We've learned things like incidence and case rate. And many of you may have become familiar with the concept of R0. R0 is the average number of people who will contract a contagious disease after exposure to one person with the disease. In endemicity, the R0 is close to 1. Case counts are neither rising nor decreasing. Each case gives rise to only one new case. Note that the formula says nothing about severity. An endemic disease can still be deadly. You know, Dr. Prasad mentioned malaria and tuberculosis in other parts of the world. Those are endemic diseases there. Next slide, please. Early in the pandemic, there was a hope that SARS coronavirus would, quote unquote, burn itself out. That so-called herd immunity, whether through infection or through immunization, would result in its gradual disappearance. But coronaviruses are wily things, and SARS coronavirus 2 has now been found, as veterinarian Dr. Jeff Bender said in their first week of mini medical school, in many animal species. And there have been a number of spill over and spill back events. So the bottom line is that SARS coronavirus 2, COVID, will flow back and forth from humans to animals indefinitely and have as much opportunity to produce new variants in the animal populations that they persist in as in humans, and those variants may spread to humans. Partly because of its presence in animals, COVID will always be with us. Last slide, please. We also forget that although the last 2 years have seemed interminable, and in fact have been interminable, have been frightening and lethal and turned everyone's lives upside down, that we're watching a novel illness spread in real time in ways that we've never been able to observe before. Maybe hundreds or thousands of years ago, when the coronaviruses that now cause the common cold first appeared on the scene, they moved through the population, certainly at a much slower pace. We didn't have megacities then, we didn't have trans-Pacific and transatlantic plane flights then, but moved through populations and caused the same level of serious illness and death that COVID has caused in the last 2 years. But then with time, once the adults who survived had some level of immunity, when children were first infected as children, when many infectious diseases are less severe and had antibodies for life, when infants received antibodies from their mothers, each new variant of the particular coronavirus became, on average, across time, across populations, less of a catastrophe and more of a nuisance. We just haven't experienced the spread of a new and novel coronavirus like this in real time with the scientific tools to plot its course. And so while we're eager for it to be over, and let me state for the record that SARS coronavirus will probably never be over, it will take years to get a handle on how it performs across populations of humans and animals, across geography and across time. We have to be prepared to be thoughtful and vigilant as we learn to live with it. And Dr. Rosenberg, I sure hope that the mini medical school final exam is being graded on a curve.
Thank you, Dr. Wurtz, and thank you to all three of the speakers. We'll move on to the questions and answers. And again, I'll remind attendees, you can enter your questions in the Q&A box at the bottom of the screen. Dr. Ikramuddin, let me start with you. The attendee asked the question, has long COVID shed any light on virally induced, poorly understood diseases such as chronic fatigue syndrome? And you're on mute right now.
There we go. Sorry about that. So yes, it did bring the chronic fatigue syndrome center stage. brought it back to be reconsidered. Throughout the years that I've been practicing, I've had patients with chronic fatigue syndrome, and it was a disease entity that not too many physicians and providers were sure even existed. I think because of the long COVID, the chronic fatigue syndrome has become center stage, and hopefully can be better explained with all the work that's going on with the long COVID now.
Thank you. Dr. Prasad, do you think the lessons learned during the pandemic could help improve social determinants of health?
Dr. Rosenberg, that's a wonderful question. And my hope is yes. And the reason for this is we have realized that approaches towards any of these major threats go beyond the clinical realm. If you look at terms around trust in communities, political structures, economic things, those have been important considerations as we look at resilience within individual societies, health systems, etc. So my hope is that this will bring up the premise that we need to be paying more attention and incorporate issues about social determinants of health in our pandemic preparedness and understand how we can respond to things better.
Thank you. Dr. Wurtz, an attendee, has asked, are the new and future variants likely to cause more severe disease, less severe disease, or we have no idea which way they'll evolve?
Unfortunately, we have no idea. A virus is like a person walking down the street with an enormous keychain of keys, and they're just testing every door, knocking on every door, and then testing their key in that lock. It's describing a little bit too much agency to the virus. Obviously, its mutations are completely random without any purpose in mind. So unfortunately, there's no predictability about how it will evolve.
Thank you. Dr. Ikramuddin, let me turn back to you. Can long COVID develop in people who have had mild or asymptomatic disease?
Thank you for the question, Dr. Rosenberg. So yes, it can definitely develop in mild cases, and I have seen that in my patient population. Asymptomatic, that we would need more information on that. Is that asymptomatic in the setting of a positive test, or is that asymptomatic in the absence of a test? Because one of the way to diagnose it is either by PCR rapid test or by clinic symptoms. But if even the clinical symptoms are gone, then you have to make sure that you're ruling out other causes. Thank you.
Great, thank you. Dr. Prasad, you mentioned the effects of the pandemic on poverty and future generations. Is there any way to intervene or interrupt this earlier rather than later?
That's a good question. I think the challenge has been that how do we intervene with economic development quickly, right? So if you look at societies that have been disrupted today, Sudan has been facing a downturn, Sri Lanka is in the verge of complete collapse. Those are multifactorial. And some of the tools that are available from the macroeconomic viewpoint might alleviate some, but there is an urgent need to intervene, particularly around nutrition issues. Unfortunately, the war in Ukraine is added to it because a significant amount of the world's wheat come from either Russia or Ukraine. So in many countries that are depending on wheat as a staple, that's an added burden. So those are important questions. How do we do emergency food relief so that the nutritional aspects are taken care of? They can be intervened, but do we have the mechanisms to do it is a big question. So,
thank you. Dr. Wurtz, there's rumor that the Zika virus could be the next big thing. What can we do to prepare for the next pandemic?
I think it's unlikely that Zika will be the next big thing because it's really not passed from person to person easily. It's not a respiratory virus. So that said, there are many candidates for the next pandemic virus. And God forbid, but it's possible that the next one would make COVID look like, a kindergartner. It's absolutely essential that we learn everything we can, despite all of the evidence to the contrary that we haven't learned lessons yet. It's absolutely essential that we learn everything we can from what we did well and what we didn't do well in our response to this pandemic, and create the scientific and the social infrastructure to respond more effectively next time.
Thank you. Dr. Ikramuddin, an attendee asks, some pre-existing autoimmune conditions have been flagged as a potential risk factor for long COVID. Some data suggests this is specific to lupus antibodies. What are your thoughts on whether any autoantibody also serves as a risk factor?
It is a very excellent question, and I think much more research is needed to answer that question. In my clinic, for instance, I have a patient with Hashimoto's, and many of the symptoms were so exacerbated. So the question is, were the antibodies enhanced, or what was the mechanism of that unmasking? So too early to say. My thought is there are antibodies to many organ systems based on the angiotensin converting enzyme 2 receptors that are present in these organs.
Thank you. Dr. Prasad, vaccine equity question. What can health organizations and the public do to improve vaccine equity in areas around the world where vaccination rates are low?
The interesting point here, Dr. Rosenberg, is that in many countries, vaccine acceptance generally has been very high. So in general, if you look at childhood vaccination rates and things like that, in many countries are much better than many parts of the US for that matter. So it becomes an important question about supply. Early in the pandemic, actually in the middle of the pandemic, I shouldn't say middle, a year and a half ago, there was a lot of donated vaccines that were being sent. And that led to more problems, because you have to really understand that you can't just dump vaccines and assume that people will say, hey, this is fine, we need to take over this. The question about vaccine equity has been stuck in the premise of who owns the rights of it. And do we have vaccines that are now in quote unquote public domain, so people can now manufacture it in the countries and then distribute it better? So a lot of the questions around vaccine equity go beyond health policy, though they go to trade policy. And how should we look at trade policy? We talk about global health being multidisciplinary. Here is an example. Trade policy being a very important consideration in vaccine equity. What can we do? What can the general public do? I think it is getting our political representatives involved in making changes in trade policy so we can achieve the equity at a macro level.
Thank you. Dr. Wurtz, how can we promote awareness while discouraging misinformation regarding this move to the endemic phase of the disease, if that's where we're going?
I think it's an excellent question. I think that one of the unique features, or the unanticipated and unprepared for features of this pandemic, was the role that social media and the ability to share a message without critically evaluating it, share it easily, the amplification of wrong information and its distribution and dissemination, the role that it's played in the failure of our response to the pandemic. And it's certainly going to be critical for public health to learn better how to navigate information and communication in the social media age, something that as a public health person, I think honestly we were unprepared for and did not do well with. And so I think to learn more about how to use social media to overwhelm the misinformation with the right information is going to be critical. It's a super important point.
Thank you. Dr. Ikramuddin, you talked about finding virus in brain. Has research identified any triggers for the post-exertional malaise or feeling unwell or exercise intolerance? What brings those on as prominent symptoms?
It's tough to say the mechanism of it, but the symptoms that that it can bring on are very simple. It could be as much as the patient taking a shower that produces the post-exertional malaise. It could be something such as attending your child's conference. For many of the patients, especially with long COVID, when I ask them to prevent deconditioning in the setting of this severe fatigue, I have to be very careful when I ask them to go and take a walk, because that walk can result in the post-exertional malaise. One of the thoughts, one of the treatment options that I see, or strategies that I see, is teaching the patients how to grade their own malaise or their own fatigue, and to keep them with keeping that grade within a certain number and not going beyond a certain number, so that you are not paying for it the next day.
Thank you. Dr. Prasad, a questioner asks, what's the University of Minnesota doing to aid other countries, and gives the example of Nicaragua, Cuba, and Central American peoples, how have educational or actually healthcare aid products learned from and collaborated with these people in the ongoing pandemic?
Dr. Rosenberg, that's a wonderful question. In many ways, the COVID pandemic has become a strong reset in how we have looked at global health. It's moved from being an aid or a charity-based system to asking questions about, shouldn't we learn more from each other? Because there are many countries who are doing much better than the US in controlling the pandemic. So our approach has been, what is it that we can do to learn from and with each other? We have done a partnership with an entity in Ghana through which we have amplified some of our tools, an online platform, for example, to do more health dissemination. And we are here to say that it's not about, saying that we know all the answers, which shouldn't be the way we should look at global health. It's about what is it that we can learn together in all of this. And that is the approach we're taking.
Thank you. Dr. Wurtz, you're going to have the last answer. And the question is, the pandemic has shown the need for the general public's participation in public health. How can community members get involved to impact their community's health?
That's also a very important question. I think to spend time engaged in community organizations that don't necessarily focus on health. We like to think that public health really covers almost every aspect of life. So things that address education, things that address housing, things that address inequity in income, all of these problems and underlying infrastructural problems have contributed to why COVID was so devastating in the United States. And so to work in the organizations that you already belong to, in the faith communities that you already belong to, in the educational institutions that you and your children belong to develop more cohesion and more trust and more knowledge about the important role of equity and engagement in communities and trust, and to learn together more about how to improve our social infrastructure.
Thank you. And I think because of time, we're going to have to leave the other questions, but I really want to thank our panelists for both your time today and sharing your insights into long COVID, global health, and an end to the pandemic, and for all the work you're all doing to help all of us. Special thanks to all of our attendees and for the excellent questions that you posed. This is the end of this series of Mini Medical School, and although we're not quite ready to grant you all MD degrees, we really are grateful for your participation in this series. And with that, I'll close and thanks to all of you.